and everything is running smoothly. So the first thing is I want to mention is that I do research with Professor Diadona and the Catholic University of Rome and another one also in Spain, the University of Basque Country. I have no corporate affiliations, so basically be rest assured that I will not be trying to sell you anything, okay? So no company pays me to say anything here. I'm gladly sharing my cases and research with you. I hope you can enjoy. The whole point of this presentation is to disseminate knowledge. So I'm going to basically divide the presentation in different blocks, a little bit of an introduction at the beginning, followed by some research that will be on and off, of course, not all the time, mixed with a lot of cases. Hopefully, we can see a lot of cases. The main topic, of course, is periosteal guided bone regeneration. That is my philosophy of work, the rationale for what I do. You will be able to see throughout the presentation, the biological rationale, that is. And I basically don't use biomaterials. I use only autogenous tissue and the power of the periosteal membrane. We are going to talk also, and this is part of my research, the idea of using for reconstruction either autogenous blocks or what we published already some seals, which are also blocks but much thinner and revascularized much faster, and they don't need fixation. That is the main difference, fixation versus non-fixation. And then, of course, we will talk about basically that idea will evolve into the two different options of states versus simultaneous. When I talk about states, implant placement, it is basically augment first, wait for healing, and then place the implant later. That is a states approach versus the simultaneous. You do everything at the same time. Implant placement and reconstruction, as you can imagine, is much more difficult as we move into severe bone defects that can be very challenging. And I want to ask you to pay attention like little kids do. Little kids tend to absorb much better. So by means of simple observation, I think you'll be able to learn quite a bit. I believe in definitely sound foundations. That's the reason why I do the things I do. I believe that a sound foundation will deliver that implant we are going to be placing in our patients' mouths long term. The whole concept of building a strong foundation 360 degrees around the implant. So I want my implant fully surrounded by bone and autogenous soft tissue. There is a reason why I always say this, and I'm very close to, of course, Rome, Professor Diadona. There's a reason why the Pantheon is still standing. So there's a few questions that I will be asking throughout the whole presentation again and again, and hopefully we can answer every single one of them throughout the presentation. I'm not going to give you a straight answer right away, but you will be able to answer every one of them throughout the presentation when you see all the cases. And one of them is how well can we avoid, especially these days, we're trying to do everything minimally invasive. Can we avoid bone augmentation altogether? Obviously, when we are dealing with a severe defect, that is not possible. Is it the buccal bone, the facial bone, important? Because these days there are some, you will see some researchers that are suggesting buccal bone is not as important. They believe that the thickness of the soft tissue is enough. So we'll be answering that question as well. The provisionals, I believe the provisionals are extremely important, especially when we are talking about pink aesthetics. As a periodontist that I am focusing mostly on achieving a good pink aesthetics so that basically everything looks natural. So what is the importance of provisionals? And again, we will be also talking about stage versus simultaneous, which one is best, and if we can do everything at the same time or not. But there's plenty of research showing that the fragile foundation of anterior teeth, it can be challenging, especially when we have to place implants. Because just think about this: over half of the buccal of the canines and central incisors, over half of those have a buccal bone thickness less than 1 millimeter thick. So when we're talking about less than 1 millimeter thick, that means that sometimes we don't even have a millimeter. We're talking about a fragile foundation that can lead to bony collapse the moment that tooth is extracted. So keep that in mind. All anterior teeth are special, and I think they deserve a special attention. The anterior, especially both the premaxilla and the anterior mandible. There is a common pattern that I see in private practice, and that common pattern has to do with the lack of facial bone. And we can ask ourselves, why are we having that lack of facial bone on a regular basis? One of the reasons, you already saw the previous article, is because to begin with, we have a super thin buccal bone. The moment the tooth is extracted, we're dealing with basically a super thin, paper thin, or no bone at all. And we see this all the time. If we're thinking about, and these days it's very common to do alveolar ridge preservation. We'll be talking briefly about alveolar ridge preservation as well. There's been a number of interesting studies. If you're planning, basically, if you like to do alveolar ridge preservation using biomaterials, meaning extract the tooth, place some biomaterial into the socket, I think that especially for the anterior maxilla mandible, it is quite risky. Just think about this. And this is basically research data, such as the research that you're seeing on the screen. We see up to less than 60% of new bone formation when, for example, a xenograft is placed into the socket. So if we are delaying or impairing new bone formation, then we're going to have some trouble. Definitely, the message from the literature to me is clear. Bone substitutes tend to impair intra-socket new bone formation. I see these type of cases all the time. We're going to briefly explore some complications that we see in implant dentistry. And when it comes to anterior implants, it can be quite a disaster. This patient came to me, had this implant placed by a fine periodontist 8 years ago, and you can see the biomaterial inside the socket on the X-ray. I can't imagine. I mean, I don't understand the reason why this patient didn't seek help from another periodontist and waited 8 years. But the thing is that this type of defects do not hurt. So many patients are afraid of doing anything, and they don't come to the dentist. And so as a result, we end up having severe defects, very difficult to handle. The patient wanted me to, of course, save the implant, but it was quite complicated. So in this particular case, the defect was going all the way to the apex almost, and I was definitely, I informed the patient that the chances of saving the implant were very, very marginal. So what happened here in this particular case is, well, this patient probably started with a healthy peri-implant tissue that led to some marginal inflammation, and that led to some mucositis, which led to some perimplantitis. And so after 8 years, the implant loses that implant, and we have to remove it. It is quite traumatic for patients to see this. So another, again, these are some of the questions I will be asking also throughout the presentation. Is socket integrity, meaning having a socket with intact bony walls, important? Because again, there are some voices that are saying that having a buccal dehiscence, it is not that important. And what about bone versus keratinized tissue? Which one is more important? Well, we know from the periodontal literature, and this is from teeth, if we don't have bone, we're going to have a recession. So is it important to have bone on the facial all around the implant and the teeth? I definitely answered this question right away. I have to say that, of course, it is. This patient was unfortunately exposed to some iatrogenic orthodontics. The orthodontic treatment was done perhaps too fast. Possibly the patient didn't have sufficient bone or no bone at all, and that led to a rapidly progressive attachment loss on the facial aspect of those mandibular incisors, which we had to correct with a free gingival graft, and it worked well. But this is what happens. Again, this is what happens when there is no bone or very little bone, and a micro-repetitive trauma or a trauma from orthodontic movement that is done too fast can lead to this type of issues. With implants, we could apply, of course, implants don't have orthodontic, but it is the same concept. If an implant has no buccal bone, definitely there's more chances of having issues long-term. So definitely, I think I have that answers your question. On teeth, we have seen some beautiful histological data. Basically, we know that these free gingival grafts have the capacity to potentially induce new bone formation, as it possibly happened in this one. So this is when it comes to implants, my advice, definitely always we have to have a nice band of keratinized tissue. My advice is to do to augment and have a nice band of keratinized tissue prior to implant placement. It will be easier for you to manage the site if you augment first with a free gingival graft, and then you can place your implants and have a nice band of keratinized tissue, both buccal and lingual, that will protect the area from bone loss. Those thick, the keratinized tissue basically does the job of creating a band of protection, if you put it that way. So in this case, definitely what I did was to, again, place a nice large free gingival graft on the buccal of that area and did the implant surgery later on. So, and that has shown to basically lead to stable tissues long term as well. So definitely, it is not just about the bone, but also the keratinized tissue. Cases like that, like this one, have been referred to me also for augmentation. Definitely, I advise you to do it earlier, but these implants were placed by another colleague of mine. I want him to have some keratinized tissue. Definitely, that is doable and advisable, especially on an older patient. We're not going to do any major surgery, but providing a band of keratinized tissue to those implants that are holding an overdenture is always a good thing to do. So I advocate the use of what we call pre-prosthetic free gingival grafting to basically augment prior to implant placement, and then later on you can go ahead and place your implants as needed, as many as you need for an overdenture or briefly some biological complications. I'm not going to spend too much time on biological complications, but I want you to know that this is part of the deal. When you're placing implants, and the more you place, the more chances, the likelihood increases, chances of having complications. So there is a nice letter. I'm not going to spend too much time, but there is a nice letter written on the reasons why implant dentistry, modern implant dentistry, is having so many issues and complications. This is one of them. These implants were placed by a colleague of mine, and he experienced a rapidly progressive bone loss on a number of implants. We didn't know what it was. We published this on International Journal of Perio and Reconstructive Dentistry. Basically, we have to be careful with these patients that have history of severe periodontitis or aggressive periodontitis, like we used to call it before. Because the main issue here on this particular patient is that, well, apparently he was a periodontal patient. He transitioned into full, as you saw, full maxilla implants, and there's only 3 teeth left on his mouth. If these patients happen to get infected or have the microorganism that can cause bone loss rapidly, which was the case, we can be in trouble. Also, we have to be careful with the prescription of antibiotics because systemic broad spectrum antibiotics can create a dysbiosis that can lead to actually the appearance of superinfecting agents that can lead to severe bone loss around those implants. In this, I follow this patient. Basically, what I did, I was not treating the patient, but I was taking some microbial samples, and what we saw was that he did have a series of superinfecting agents, starting with enteric rods, then yeast, and ultimately Agrobacter and Actinomyces concomitans, which is, as you probably know, one of the most aggressive pathogens that we can. If that happens to you, unfortunately, it is difficult to treat. But we know from studies like this one that those microorganisms invade soft tissues, and when they invade soft tissues, they can be difficult to eliminate. So surgery will be advisable. We published this also in Arcas Oral Biology. Basically, the idea is to, on a patient that has had history of periodontal disease, we have to be more follow up them much closer, because we need to be able to detect a change in the ecosystem or any type of marginal inflammation that can lead to the cases that you saw earlier of severe bone loss. Also, the modern implant surface topography leads to potential complications, as you can imagine. These implants are rough, and they are going to basically create a surface that is difficult to clean and to maintain clean once the surface gets exposed. I'm going to show you a series of complications. This is one of them. One of my colleagues did some GBR and biomaterials on this canine that, well, it kept getting worse and worse, and the implant had to be removed. The problem is that when these complications happen, sometimes the adjacent teeth are in trouble, which is the case. The lateral incisor is going to have to be removed. Also, we see this type of what I call unscrupulous dentistry, and so don't be driven into it. This patient was referred to me to place an implant when he had already multiple implants placed, and one of them had moved into the sinus. So this is what we see. This is what I see on a regular basis in private practice, and believe me, it's not fun. So talking about strong foundations, I do believe all buildings, as you know, have strong foundations. That's why they last centuries. But if you're one of those that believe that your bone or a strong foundation is not important, you can go by the concept of the stork nest, which is that little nest. I don't know if you know the storks. Those are the birds that live at the edge. I believe that implants should not live at the edge, and we want to have strong foundations. We're going to talk about symmetry versus beauty. Symmetry is important. And talking about complications, this is another complication, an implant, a couple of implants that had been placed by another colleague. As you can see, the implants were placed too buccal. The patient came to me for advice. The chief complaint was pain. And so when we look at the x-rays, well, the x-rays, well, you see that there is some bone loss, but the clinical picture is what denotes the main issue. Those implants were placed too buccal. So as you already know, the buccal is already thin. If when placing your implants, you're placing them too buccal, then you're going to have this type of complications for sure. So precise 3D implant placement is key to avoid this type of complications. I mean, just think about that restoration. I don't know how in all the world the restorative dentist was able to put that restoration into that implant. But so symmetry versus beauty. As you all know, symmetry is one of the parameters of aesthetics, and so there's been some controversy on whether we need a perfect symmetry or not, and if that is a parameter that we should follow. Remember this: some degree of asymmetry is fine. some degree of asymmetry is fine. If we are to explore and examine the distance from the CJ to the incisal edge of all your canines and compare them canine to canine, all the lateral incisors, lateral incisor to lateral incisor and central incisors, you will see that there is a discrepancy. We humans are not perfectly symmetrical, so some degree of asymmetry is fine. And when we do this, for example, on aesthetic crown lengthening, we see that sometimes there are slight discrepancies at the end that you need to inform the patient. With implants, it's the same. Think about that. Okay, we are aiming, especially for the central incisors, we're aiming for perfect aesthetics, and that's why we want to make sure that we have a good asymmetry with the central incisors. But with the rest, there is some degree of asymmetry is fine. This case was basically, I'm trying to use case of aesthetic crown lengthening. It's not implants, but the idea is basically that I wanted to bring about is the concept of asymmetry. And of course, when we have this type of cases, we need to do we need to remove a number of, we need to do a osteoplasty and an osteectomy to harmonize the osseous structures, and we can provide the best, closer to the best symmetry possible. The only thing is that sometimes patients may see that this particular patient was very happy with the result, but if you notice that the lateral incisors are slightly different. So again, the concept of asymmetry, this patient had orthodontic treatment done, and we see that it was sent to me to treat that recession. But look at the lateral incisors. They are one lateral incisor is longer than the other, so some degree of asymmetry is considered harmonious. Is a natural harmonious asymmetry that patient actually doesn't really. So implants, were starting with implant cases. The concept of pink aesthetics was developed by Furhauser in 2005. He's a prosthodontist, but basically he came up with the, I don't know if you're familiar, we're not going to go into detail. You can look it up later on, but basically he described pink aesthetics as obviously having proper symmetric papillas between the contralateral implant sites, the level of the gingival, of the mucosal margin, etc. And so I am basically going to focus on pink, not on white aesthetics, because there's also another score, the white aesthetic score, that I'm not going to focus on. I want you to know that I don't do any of the restorations. Basically, I am only a periodontist, and so I'm going to focus on the pink. The crowns are done, and all the restorations are done by the restorative dentists that I work with. This, as you can see, this case on the top was treated in a staged approach. Block augmentation was done first, and then we ended up with this type of implant placement for the lateral incisors. After 14 plus years, the case was looking beautiful. So we can consider, from a pink aesthetic point of view, a success, as opposed to the case on the bottom, which was a failure. That is not my case, by the way, but it was a case that came to me to ask me for advice, seeking advice for the lateral incisors that had some deep pockets. We will talk about that later on. So can we avoid, in cases like this, bone grafting? Oftentimes we are going to find ourselves having to perform difficult surgeries on the anterior maxilla. But we can avoid a lot of these complications. We can limit the number of procedures and the augmentation procedures, or the difficulty of these augmentation procedures, starting with the Atraumatic extraction. And that is key. These are two different patients, left and right. They're missing the same tooth, the canine. And so, well, the concept of how to restore these cases, and I want to bring the idea of, should we do block grafting? Should we do the cortical seal? you can do GBR with biomaterials, of course. Remember, I only do autogenous, so this is what I will be showing you here and will be sharing with you. So again, similar case, 2 different patients. We have a traumatic extraction that led to severe bone loss, so the whole buccal plate is missing. The case on the right was an impacted canine, so the surgeon that extracted the tooth had to remove a significant amount of bone. The case on the left, I don't know what happened, but the surgeon that extracted the tooth, well, it did cause a lot of problems. So can we avoid, again, bone augmentation? Well, we can avoid bone augmentation, especially if, again, if we do an extraction that is not that traumatic. In this particular case, I was able to place this implant without any bone augmentation, so no bone grafting was done. The only thing that I would have liked to have from the restorative dentist is a provisional restoration to shape that gingival, that mucosal margin, sorry, and basically have a better and more ideal pink aesthetics, okay, a more symmetrical pink aesthetics with a contralateral canine. So we can basically do everything and avoid significant bone grafting if we do the extraction with care. And when I say with care, I always like to use on cases like this was referred to me for that canine. Again, we're seeing, as you can see, a number of canines now. The left canine was needed to be extracted, and I basically the first thing that I asked the restorative dentist was if we could save that tooth, because it's a pity to extract a canine with such a long root, but he said that it was unrestorable. So the idea is here to, I always use in these cases the piezo device to extract the tooth, and don't be afraid if you need to raise a flap in case you need to do any type of augmentation, or if you want to confirm that the buccal plate is intact. So with a piezo device, you can be much more gentle and extract the tooth, preserving the whole buccal plate. And well, remember, especially for canines, I think you have to be especially careful because they have long roots. So a lot of trauma can happen if we are not careful. And now you can do anything you want after extraction. You can do an immediate placement, like is the case, or you can wait, you can grab if you need to grab the site. And that is another question that we'll be asking. Do we need to grab the gap after a tooth has been extracted? We will talk about that in a minute. In this case, I did some particles of autogenous bone that I harvested from the curiosity, mainly because it was a large socket. And so I wanted to enhance or boost that healing. I know that those particles of autogenous bone will start shedding osteoblast into that socket in as little as 9-10 days. And I know that from research that we have published that I will share with you in a little bit. So again, we were able to place the implant, and the rest is history. I will show you more cases in detail, don't worry. So going back to the 2 cases, on the case on the right, I basically did a stage approach. I consider stage approach better, and I think in these cases it's better. A stage approach basically allows us, gives us more control over the augmentation sites, and we don't have to do everything simultaneously, which can be sometimes very, very challenging. And so everything healed fine. The rest is history. On the case on the left, I didn't do the same approach. I didn't do a stage. I did everything simultaneously, which is quite difficult, but it can be done. It can be done, and that is the concept of the cortical seal that I will show you more in detail in a little bit. So the case was restored like that, and we were able to restore both the buccal bone and the keratinized mucosa, because remember, we want keratinized mucosa back out to that implant. And this is the case before and 36 months after. This patient has been like this for now over close to 6 years. We have a relatively good pink aesthetic score, but well, this is, again, I'll show you in a minute, a little complication that we had restorative wise. This is the article that we published in JOMI in December 2022. Basically, the idea is to create, again, for simultaneous implant placement, the idea is to create at the same time that we place the implant, reconstruct that socket, create like a 3D volumetric 360 degrees casing around the implant, so that we can basically promote neo-angiogenesis, neo-osteogenesis inside that new socket or new reconstructed socket that we have created. And this all happens quickly because of the concept of periosteal guided bone regeneration. We have a number of cases on following this concept of simultaneous implant placement on severely damaged sockets. So simultaneous implant placement and socket seal. I call it a seal, even though it's a block, because it's very thin. It's not like the usual blocks that we use in a two-stage approach. And they revascularize quite easy. I combine the seal with particles. Again, I will go in detail in a little bit. We are still in the kind of an introduction. So going back to this case with severe bone loss, it is going to be difficult, as you can imagine, to place the implant and reconstruct simultaneously. But I mean, depending on, the first thing you have to analyze, evaluate is your CBCT, your CAT scan. And that is going to give you an idea of what you can do or you cannot do. This is the pre-op CT scan. And as you can see, there is a severe deficiency on the buccal aspect, vertical, both vertical and horizontally. So if we are to place that implant and reconstruct at the same time, without fixation, that is going to be some challenge. The idea is to create, by friction, we are trying to create, it's like a puzzle, like the piece of a puzzle. And in these cases, I always prefer, of course, tuberosity. The tuberosity bone is more softer. You can actually bend it. But notice, in this particular case, notice that the adjacent teeth, both the lateral incisor and the premolar, the patient had orthodontic therapy. Notice, basically, they have no bone on the buccal aspect as well. Lateral incisor and the canine, the premolar. The premolar has that root completely out of the alveolar process. So overall, it's a difficult case. The idea is to create, basically, again, like the pieces of a puzzle. The implant is going to go before I place the blocks, before I place the seal. It's going to go, I'm going to insert the implant on the site, and you have to make those pieces that you harvested from the tuberosity fit the site. So I harvested 2 little seals, as you can see, from the back of the tuberosity. In this case, the patient was a good donor, and place the implant and place one block and another. That is the first block, and then another one that I place over the implant. It was difficult enough to take pictures, so I don't actually have, but I do have the re-entry at 17 weeks. Basically, the implant is fully surrounded by bone. That is the block and the one above. And later on at uncovery, basically, our incisions should be done more towards the palatal so that we can bring that keratinized tissue towards the buccal. And so our provisional is to push that keratinized tissue towards the buccal. And so this is what we see. And what we see here is I was telling you that about the little restorative complication that we had. The first picture here, number one, was done by a different dentist. Was done by a dentist that perhaps was not too expert on implant restorations, but he did what we call a ridge lap, which is basically that restoration has a nice ridge solder that is sitting over my keratinized tissue. So it's smashing down the keratinized tissue. You have to be careful with that because these type of restorations are a mess and they can cause a lot of problems down the line. Apart from not allowing the keratinized tissue to do the job of cleansing. So I asked the dentist to remove the crown, and basically I wanted not only, also this restoration was a cemented one. I asked the dentist to deliver a screw retained restoration without that ridge lap, which is what he did. This is the provisional restoration. The tissues are still a little funny there because he had some struggle to remove the crown, and later on this is the definitive restoration. And you can see our band of keratinized tissue, which we're supposed to have. Prior to that, that restoration was lapping, reaching, or sitting over that keratinized tissue, which that should not never happen. Just keep that in mind. There is a number of studies on the design and the problems that we have with the prosthesis design over implants. Definitely ridge laps or those solders should always be avoided on, especially on any tooth, but more so perhaps on the anteriors. So again, we go from the cement restoration at the beginning with the ridge lap to the final restoration screw retain with convex profile, no solders, and that's what you want to see. So an ovate pontic. You can see, you can compare the contralateral side. The dentist decided to close the space. Actually, he didn't have to, because on the contralateral side, the patient has an space. So you could have leave that space open. That would have been a problem. But anyway, that's what the restorative dentist decided to do. The PAs at 12 months and 36 months with good bone levels. And 36 months, this is the screw retained final restoration. So we're reaching the point where I'm asking you again, what do you think? Is rigid fixation the way to go, or is better non-rigid fixation, like such as the cortical seal that you see on the right? Obviously, there is advantages and disadvantages of every technique. The simultaneous non-rigid fixation that you see with the seal, cortical seal, here on the right, it is very technique sensitive. So it's not easy. I don't want you to start doing things that you don't feel comfortable with. The Esthetics approach, on the other hand, you have more control. You can fixate your block. You have more time for the healing, especially when we're dealing with large defects, especially when we're dealing with what I call a cold defect. Cold defect is that it's not hot anymore. When it's not hot, it becomes flatter, it's more difficult to treat. So we have a number of quantitation studies. If you are planning, or if you want to do autogenous bone grafting, you need to master your knowledge on CBCT reading and knowing the different areas where you can harvest from. Traditionally, the main focus areas where you can harvest bone from are the ramus and the chin, but that is not all. There is a whole different world out there of different places where you can harvest. You don't need to focus on the ramus and the chin, which may be challenging and you may not feel comfortable with. So overall, you should know that there is plenty of, for the majority of the cases, there is a lot of bone that can be harvested intraorally without having to go to any extraoral source. And so on average, the average patient, we can have up to close to 8 cc's, 7.7 cc's of bone, and that is quite a lot. That is more than enough to augment both, just to give you an idea, both sinuses and more. So when we're dealing with localized defects, it is definitely even easier. But the majority of the cases, we're going to see that we have sufficient bone intraorally to harvest and for our reconstructive procedures. And so we've published, actually, for the last 16 plus years, we've been publishing on this topic, on autogenous bone and periosteal guided bone regeneration and augmentation, also on specifically more so on block grafting and the cortical seal. These are some of the articles. If you're interested, Professor Diadona can give you more information. But we have some record of publications on this regard. And so remember, the two key ingredients here are the periosteum and the bone, or the grafting material that you use. And why is this important? Because there is a compounding effect. The periosteum has a tremendous potential to shed, it has stem cells. And so the potential to shed osteoblasts into the surgical site is tremendous. Plus, it provides with 70 to 80% of the vascular rate of the blood supply to the cortex. So the compounding effect, again, of the periosteum, which is a bilayer, by the way, and this is a representation from this article published by the Harvard group, Lin and co-workers, the article that you see at the bottom. They published a beautiful article on the different uses of the periosteum for bone regeneration. And remember, again, this, apart from the uses and the potential for regeneration, because of the presence of skeletal progenitor cells and osteoblasts and pericytes, it also provides with up to 80% of the blood supply. So we don't want to block that blood supply. The AIDS has been also an issue that has been constantly, we have a lot of literature actually in this regard, whether the age of the patient is a factor in achieving good bone regeneration or not. And it is true that older patients have less healing potential, but to be honest, what I have seen both in older 90-plus-year-old individuals and younger, they heal well and fast when you do autogenous bone. And it's precisely because it's autogenous bone and not something else. So this group from Stanford, if you don't know them, I advise you to follow them. Stanford University has a strong team that has been researching on autogenous bone for a number of years, and they have a number of beautiful publications that I advise you to follow if read if you have the chance. But they are with us, and basically they say as well that autogenous bone is definitely the gold standard, and you can imagine that the biological rationale for it. But anyway, I'm not going to go into detail of those articles. You can later on, if you want, have access to them and read a bit more. But defects like this become much more complicated to treat, and there is a limit. Sometimes there is a limit to the things we can do. And I'm talking about because of the technical issues. The more severe the defect, the more bone we will need. But these defects are perfectly treatable with the use of autogenous bone. There are a number of techniques, but everything goes through and works well thanks to the concept of periosteal guided bone regeneration. Definitely, these cases, I advise to, by all means, do a staged approach. So I always use blocks and particles. And by the way, you do not need membranes. You're going to hear from a number of lecturers that you do need membranes and you get less bone resorption. The volume that you get with this type of blocks is outstanding. The resorption is minimum. it's been said, well, there's a number of actually, there's one study, beautiful study, we'll talk about it later, that reports a resorption rate of about 7.7%, which is minimum. Professor Chiapasco reports even less, 0 to 5%, to 15%. But anyway, you can definitely reconstruct these defects with, and they heal quicker than if you were using biomaterials, that's for sure. The healing times are significantly shorter. Then you can place your implant, and for that one we use a cantilever. So again, remember, it's the compounding effect, not just it's not just the periosteum, or it's not just periosteal guided bone regeneration, but it's the compounding effect of the periosteum on top of our graft, autogenous graft, that basically stimulates new bone formation. Because let me tell you, that periosteum, because it has pluripotential, you could, if the periosteum is placed onto adipose tissue, that periosteum could actually, instead of shedding osteoblasts, could shed adipocytes. So that is the beauty of human nature. This is the article that I mentioned to you about. Basically, we know that in as little as 19 days, we took some, the bone will, the particles of bone that we have harvested will start shedding osteoblasts. And that is basically what you see here. This is a particle of bone that we harvest, we put it on the microscope, and shortly after, it will start shedding osteoblasts. So in this article, we've seen that the osteoblast growth from those, this is the particle again, this one right here, under the light microscope. And these are, well, these are the maturation phases of the bone through the scanning electron microscope. But basically what we see is that, again, in as little as 19 days, that particle is going to, this is in vitro. So in vivo is probably sooner than 9 days. Probably after you place your bone graft, shortly after, in 48 hours, you probably have that particle shedding osteoblast into the site. And so it doesn't really matter whether it's less than 2 millimeters or over 2 to 5 millimeters. That is basically the beauty of autogenous bone. So this is one of the cases that I'm going to share with you as well. An implant that had been placed by a colleague, a good periodontist that likes to do socket grafting. And what happened is, well, basically the implant failed. There was a lack of osseointegration of that implant. And this is one of the questions that I will ask you. If a damaged socket has a greater bone volume loss, shouldn't alveolar ridge preservation be the treatment of choice to compensate for such volume loss? Well, we know, we're going to answer that question in a minute. We know, again, apart from this group from UK has published a number of articles. They have a great team, and this is a systematic review. Basically, they show the potential complications of alveolar ridge preservation. But they published a recent article in 2024 in Clinical Oral Implant Research. And basically what they show is that there is basically a less new bone formation intrasocket when a biomaterial, a xenograft in this case, is placed. So consider this. If you can live with that, if you are okay diminishing or impairing new bone formation, that can actually impair and lead to, as you saw, failure of an implant if there is not enough new bone formation, that the osseointegration of the implant could potentially be impaired. So in this particular case, well, remember this. The idea, I'm going to show you in a minute the results of this study, but the idea is that socket grafting does increase the healing time, so you will have to wait longer, and it also reduces new bone formation. So the 3 groups from this study, basically 2 had a xenograft, 14 patients in each group. and one didn't. So what they show is, you can see the particles of bios inside the socket. What you're going to see again is a reduction in new bone formation. You will have much more, up to 60% more new bone formation when a socket is left to heal without a biomaterial inside. There's been also a number of more and more reports of infection associated with alveolar ridge preservation, perimplantitis, mucositis, and there's now we have a different term, perigraftitis. So that's interesting. What we know is that if we extract the tooth and there is no facial bone, there is a good chance that that facial bone will repair itself. We have published this nice article on over, well over, it was 90 patients actually. So what we saw is that most sockets repair themselves without the use of any biomaterial. The moment we place something, we are definitely reducing the chances of that socket to repair itself. So going back to the case, the implant was removed, and this is the picture, the clinical picture 3 months after the implant was removed, the canine. So you can see still the biomaterial present. One of the questions that you probably ask yourselves is, well, if we remove that biomaterial, what is going to happen there? We're going to have a problem, right? We're going to have a larger problem, indeed. But that biomaterial is basically what we just said, impairing new bone formation. It is not doing anything. I could scoop that out very easily. It came out with one scoop of my, because that was not integrated. It was basically sitting there doing nothing. That's why the implant failed. So this is, by the way, 12 months post-socket grafting. 12 months, and that biomaterial still has not done much. Well, it basically did a lot, actually, made the implant fail. So will biomaterials create a bigger problem? I think we need to reassess and think what is best for our patients. I'm going to definitely remove the biomaterial and reconstruct it with a cortical seal approach. I harvest a couple of little seals from the tuberosity area. I can place my implant simultaneously and reconstruct the socket on the buccal and intra-socket. Basically, I use 2 tiny seals and particles that will lead to new bone formation quickly in a short period of time. And as you can see at uncovery, that is hard bone. You can do the uncovery on these cases as little as 3 months. So that bone heals quickly. That is, again, the intrasurgical and the post-GBR. This happened to be 5 months because the patient wouldn't come earlier. But anyway, you can go as early as 3 months. And that was the defect before. And after reconstruction, this is the process. So the implant is actually inside. We look at the contour is pretty well maintained after the cortical seal approach. We expose the implant, we place the healing abutment. And this is the process with the provisional crown. Remember, when we place your provisional, you're always going to see at the beginning, the first at delivery, that there is basically the intraproximal areas do not fill completely. Do not be afraid. You need those intraproximal areas open so that the papilla can travel and fill in the spaces. Okay, and that will happen. This is the final restoration. And this is a screw retained restoration. The patient is happy because finally she has a tooth. So, okay, let's move on. This is another patient, again, that we saw it earlier. You can appreciate the particles of this is over 9 years after the implant had been placed on a young girl. came to me for evaluation of that lateral incisor because she had been told that the implant was having some deep pockets, and so indeed had 10-12 millimeter pockets. And you can see particles of the biomaterial still present around that implant. As you can see, failure, it is not going to happen in these cases. It doesn't necessarily have to happen right away. You will see it sometimes years down the line. And sometimes the patients are scared to go back and ask if there's anything wrong. So they wait, and then you see the results. I'm going to share quickly with you these cases with different degrees of severity. They are all right central incisors, all of them. From left to right, again, you'll see, I'm going to show you most of the details, but I want to try to go as quickly as possible so you can see more cases. And these are some of the questions that, again, we need to ask ourselves. Again, we keep asking the same questions. Can we avoid bone augmentation? Can we keep it simple? Definitely the main concept, whether you do bone graft or not, simultaneous or not, try to keep it, my advice, try to keep it as simple as possible. So this is what we did, 3 immediates, 1 early placement and 1 delayed placement. The first one, an immediate case, fracture in central incisor, combined vertical and horizontal fracture. Implant was placed after the extraction immediately. And that is the result at 21 years. Did we need any type of bone augmentation, bone grafting, or soft tissue grafting here? No. Not at all. One of the key elements in this case and in most anterior cases is the provisional restoration and the final restoration. It has been shown clearly that, especially if the socket is intact, you do not need to put any grafting material. Now, if it makes you feel better to put something, go ahead. But the study by Furhauser and co-workers have long-term data, 5-year, and I'm sure they have more than that. But they published a nice 5-year long-term data on immediate implants with intact bony walls, with no grafting whatsoever, and showing great pink aesthetic scores at 5 years. This is a 21-year follow-up. The results are quite good. The patient is very happy. Bone levels are very stable. These are 2 different pictures that I took with the ring and the twin flash, just in case you wanted to appreciate the difference in texture, which you can. But so the left central incisor needed a root canal. It was necrotic because of the trauma as well, so it was done later on. And this is the 6-year and the 21-year follow-up with stable mucosal margins and good, perfect pink aesthetics. So this is the Furhauser study that I was mentioning to you earlier. No grafting of any type was done, but all the patients received an immediate restoration, immediate implant-supported restoration. That is another key aspect that we have the time, hopefully we can talk about that. Ideally, yes, the restoration can place, it has some significance, a nice restoration. So for that, I don't know if you do those yourself. I don't do any of them. But I think it's key to work with the right restorative team to deliver proper aesthetics. Case number 2. The patient had a bicycle accident, fracture central incisor. We wanted to double check that there was a fracture, and it seemed to be a fracture on the palatal side. So I wanted to raise the flap to double check. There was indeed a defect, and you can see the fracture as well, the horizontal fracture there. So unfortunately, the tooth had to be extracted. This is the CBCT. You can also see the bone loss present on the palatal aspect, the immediate implant placement at the time of extraction, always aim for a buccal, sorry, avoid buccal, or always aim for the palatal singular position for screw retain. Although there are a number of dentists that are fine if you place them at the incisal edge. But anyway, I prefer definitely try to go palatal. You have two options. Again, you can either, I would always recommend to put a fixed provisional restoration, but you can do a fixed implant provisional restoration over the implant. But if you don't have good primary stability, or you don't trust your restorative dentist, and then you can do a fixed Maryland bridge, something like that, that can basically help guide the tissues and the papilla during the healing process. In this case, we use the same patient's tooth that the restorative dentist was able to fix, like a kind of a Maryland with some composite. But you can see a little bit of composite buccal and palatal. But I asked him, you always want to leave spaces so that the papilla can breathe. Leave always, don't smash down that papilla. So that gap you don't need to grab that gap in this particular case. I did place some bone tips because I harvested connective tissue graft from the tuberosity, and I did place some bone tips, but honestly, in this particular case, it was not necessary. The buccal bone was intact. There is, if you believe that you need to graft, there is literature and research for every site. This one is a systematic review, shows meta-analysis, shows that yes, if you do put something on the gap, on that gap, you will have less, up to 0.6 less millimeters of resorption of bone loss. Well, I mean, the clinical significance, if you place a gap, I mean, a graft or not at the gap, is very small. But again, you have the literature that suggests, that supports the use of grafting that gap. Okay. So for immediates, it's especially tricky. Always, I advise you always to look at the convergence or divergence of the adjacent roots, which can compromise or limit the space. And in this particular case, also the patient had a large nasopalatine canal, so you have to be precise, 3D speaking, precise in implant placement. This is the video of the case that you just saw. Always study well, memorize your CBCT prior to the surgery. That is the fracture. When you do your osteotomy, basically aim for the palatal wall, so you can stabilize your implant on the palatal wall, and don't be afraid to take an X-ray to check. I did in this case because of the root convergence. I didn't want to cause any trouble. And you're going to see this is a parallel wall Straumann implant, which I was able to achieve good primary stability. But these days, for immediates, you'll have a much better primary stability if you use a taper implant. Taper implant is the way to go. So this is briefly a series of the X-rays with the implant in place and the provisional. Again, the provisional is the same tooth that the patient had, like a Maryland bridge that the restorative dentist was able to use, and it worked well. Later on, the patient went on and saw a different dentist, a prosthodontist, to do the final restoration. That's the restoration of 48 months. Well, this patient has been like this for over now 6-7 years. What happened here? The prosthodontist convinced the patient to do some retraction, intrusion, level, and alignment, which I wasn't very happy. I wasn't very happy because the implant was in. But anyway, that's what the restorative dentist, the prosthodontist, wanted to do to create a more slender profile, blah, blah, blah. This is the final restoration, and notice the nice convexity that you want to see to push that buccal mucosa towards the buccal. These are the final restorations. That's screw ungraded screw channel, and the prosthodontist also did some veneers as well, which, well, that's the final restoration. And that's the final restoration. This is, again, the patient went through those incredible 3 years of orthodontic therapy, which I think were too much, but the end result is not that bad. This is a CBCT scan of this case, taken at 4 years, 3 months, and you're going to see basically a nice buccal bone formation with an average of about close to 2 millimeters of facial bone, which is more than we would see on many of the teeth. If we are to compare the buccal bone of that implant versus the tooth when it was before it was extracted on the left, you see that the tooth has significantly less buccal bone than the implant, which is also what we want to see. On average, we should have more facial bone on our anterior implants than the adjacent teeth. So another case of immediate placement trauma, a kid that was going to the military, so we had to rush to do the implant placement and the restoration. So basically, this is to show you that you can have two types of fixed provisional restorations. I'm sure you're going to have more information tomorrow with the lecture that you have. But the way I do it, if you don't feel comfortable doing an immediate implant supported restoration at the time of implant placement, you can do the Maryland bridge as a means to guide a little bit, have guided the tissues a little bit. Then after implant uncovery, you do your implant supported provisional restoration, which will further guide the papilla and the tissues. And that's how we can sculpt and shape guide the tissues to create the proper emergence profile around the implant. The patient went to, again, back quickly to perform his duties for his country. The case that I want to show, this one is the third case, is what I consider we always have to stare and show failures. This is what I consider a failure, because I think you will learn much more from a failure than from all the successes. So this is an immediate, also central incisor, fractured tooth. This is a fractured tooth, and the restorative dentist wanted me to place an implant for him. That is the tooth after extraction. The implant was the same way as you saw before, placed using anchored on the palatal wall, a good prosthetic position towards the palatal. Now you can consider to graft or not graft that gap. There was actually no need to grab that gap because the buccal bone was intact. I did place some, again, harvest some autogenous tips from the tuberosity and place a little connective tissue over it. Quickly done. That's the implant in place immediately. And so basically, this is what we see after during the healing time. One of the aspects that I didn't like from the beginning was, well, the patient didn't have. So this is at the time of healing after implant placement. You can see that we still have a margin of security there, a good band of keratinized tissue that we can use in our advantage. So that's when the implant was placed. And this is 4 weeks. 4 weeks after, we have a pretty good volume to make things look beautiful. Okay, so far so good. We have all the ingredients to make that implant look beautiful. That's the x-rays at the time of placement, 12 weeks and 12 months. So far so good, right? Well, this is the final restoration. What happened here? So what happened is basically, number one, there was no provisional phase. The dentist, which happened to be not a very expert dentist in restoring implants, place directly the final restorations, and that, my friends, is a big mistake. Big mistake. We have the volume, we have the papilla, we have everything, but so there is a mismatch. He didn't open also that space. So if we compare the papilla of distal of the implant with the distal of the tooth, definitely that will give a pink aesthetic score of not top, not the best. Okay, there is a discrepancy because that space was not open. Again, a provisional was not used. And as you know, in aesthetics, color and symmetry are key. The symmetry comes from having perfect papillas on both left and right, I mean, mesial and distal. This is the type of restoration that the patient had, a solder, again, a solder, not a convex, smooth profile. So we don't want that on anterior implants. Again, there is a lot of issues with implant restorations. Over 80% of perimplantitis are associated with poor prosthetic design. And there is, again, these are some of the literature that you can see basically describing such problems. So this is the 5-week and the 25 months. Let's take a closer look at the 25 months. We have, again, at 25 months, a beautiful volume. But what happened? Well, after I communicated with the restorative dentist and I told him that he had to put on a provisional and to try to shape and have at least that distal papilla improve a bit more because he has to smash it down, we still have a problem that has to do only with the restoration. This is an aesthetic because I told you that some degree of asymmetry is fine, but when it comes to the central incisors, the asymmetry actually, well, I mean, some patients might not take it well. The asymmetry, we need to strive for more symmetry when it comes to the two central incisors. So as a result, this is what we consider a suboptimal outcome. Even though it looks pretty much the same as the pre-op, and the result should be and could be better. It's not a big deal. We can still improve and get a great result in this case, only if that restoration was redone, replaced. Look at the volume. We have beautiful volume at 25 months. And again, this is an immediate implant placement with minimum grafting. Case number 4. This is a case, it's not an immediate case of delay. My referring dentist extracted this tooth. These are all right central incisors. And he had read about socket grafting, alveolar ridge preservation, and so that's what he did, alveolar ridge preservation, which caused this. This was the problem that I encountered when I went to place the implant. What happened here? Basically, I'm going to show you in a minute. You can see at the bottom, after the tooth had been extracted, the graft had been placed. It didn't take well. I went to place the implant and I have some problems. I had to end up raising a flap to clean to clean all that tissue that was, it looked like semi-infected or didn't look good, and I just could not place the implant. So this is the reason why. And again, this goes back to the research that I just shared with you. Biomaterials do impair new bone formation intra-socket, so keep that in mind. And this is the cortical seal. We become, I don't know if you heard the concept of ghost busters. And this is what that biomaterial is a ghost inside the socket that needs to be removed, clean out. So that is basically what I had to do. I mean, I could have basically not placed the implant, but I decided to do the socket seal in this particular case because, this was a police officer, very busy. He wanted to have everything done as possible, as soon as possible, etc. So that's the type of defects that we can. This is what I consider a hot defect, and it's easier to treat with the, I mean, basically using pieces of a puzzle. The implant is placed at the right depth, about 3 to 4 millimeters from the adjacent gingival margins. And that's the x-rays before and after placement. That's the seal, basically, that is tuberosity bone used as a seal to cover, to create a new socket, reconstruct the socket. The implant is inside. This is at the time of uncovery. You see that it has taken fully, that implant is inside. So we need to expose the implant, place the healing abutment, and you're going to see that we have a nice buccal bone, about 2 to 3 millimeters thick. And now, of course, it comes the second phase of provisionalization, and that is key. This dentist knew a bit more about provisional, so he placed a provisional, we play with it a little bit. I asked him to open the contacts, especially at the midline area. And so that is key. I mean, that's basically only what he did, opening up that space. It will make a difference in your pink aesthetics. So basically, spend some time playing with your provisional, open up the spaces, because if you shut down those spaces, as you see here, the papilla is not happy. Here is not happy either. There's too much pressure, so I asked him to open up so that we can have a final results with the papilla and a much nicer outcome. This is what we published again in this is the cortical seal approach that we published in JOMI, International Journal of Oral Maxillofacial Implants, recently in 2022. If you want to read it, you can. I'm sure you can ask Professor Dedona to provide it for you. And so, socket integrity. We asked the question earlier of whether or not somebody, I mean, you guys asked me several questions, and one of the most recurring questions seems to be, what do we do with the gap, with the socket? Do we fill it with the biomaterial? Well, consider this, knowing what we know from the literature, knowing that a socket will have less new bone formation if we put a plug of a xenograft, for example, or anything in there. Knowing that we're going to have less new bone formation, if the socket is not intact, like this one here, like number 4, if the socket is damaged, it has a fenestration or a dehiscence or a combination of the above, that means that that socket has less potential for repair. So in these particular cases, I would definitely not even think about placing any xenograft or allograft. I think, again, and this goes with my philosophy of treatment, autogenous bone, it would be the best to reconstruct these sites. So these were 3 different cases, 2 immediate, 1 early, and remember that whatever you put in there, it can make a difference. It can be the difference between having more or less or no new bone formation. And so whatever you put in these already damaged sockets will impact the amount of new bone formation. And yes, we can get 100% new bone formation if the right principles are applied. So again, this is what the way we treat these sites, these damaged pockets with the cortical seal. We basically create a scaffold of shields and particles that we harvest. I mean, the best is definitely the tuberosity. Again, tuberosity bone is more flexible. We can use it, trim it if we need to fit that defect. This is what a cortical seal looks like, harvested from the buccal tuberosity area with a chisel. You harvest these ones with a chisel. It is much better. You can use also a piezo device if you want, depending on the thickness, but the chisels are the best they will help you basically slice out that thin layer of bone from the, we saw you these cases before. The last case is a bit more demanding. It's a case of aggressive or severe periodontitis. We published actually this case in the International Journal of Perio and Restorative Dentistry. Obviously, a patient that has severe periodontitis has to be treated full mouth first for periodontitis before we move into the implant phase. So don't remember the case that I showed you earlier of that was referred to me with full mouth implants and they were all breaking apart. That can be a nightmare. So treat always the periodontitis first before you jump into the implant phase. This case, as I said, is more challenging because it requires a number of disciplines to achieve optimal aesthetics. And one of them was orthodontics. After treating the patient for periodontal disease, the central incisor is going to be extracted, but it's going to be extracted by means of orthodontic extrusion. And that's what we did. Notice the difference that papilla was able to come down with orthodontic therapy. Actually, I don't do orthodontics myself at all, but this is a case that I did a long time ago myself and actually worked pretty well. The papilla is regenerated fully on the lateral incisor. I extruded and extracted the central incisor, and I extruded a little bit to gain some tissue on the mesial aspect on the lateral incisor. So of course we still have the defect that I had to augment with the block from the chin. I can tell you how important is the restoration, the quality of the restoration. That is key for a long-term success. And this is the patient from, you can see, March 2002 all the way to July 22, 17 years. We see that the mucosal margin has changed, has moved, and that the interincisal papilla is formed. I want to remind you that this patient had a natural diastema, and I think the prosthodontist would have never closed the space, but he wanted it closed. Notice at 17 years how the papilla has already filled in the space, even though he was a natural diastema, anterior diastema. And we see that when we do block grafting, the pink aesthetic scores improve, and it gets better and better with time. Of course, again, it is key the provisional phase. And for that, I don't do any of the restorations. This is all the prosthodontists that I work with at the time. But that provisional phase is key to sculpt and guide the tissues, the papillas, so that we can end up having a decent result. And remember that it is not easy to deal with this type of papilla loss due to severe perio. Is complicated. So that's why we were able to do it again in part, because of the orthodontic therapy, okay, and the augmentation, the block augmentation as well. So we're going to see that with time, these cases, the pink aesthetics improve. The top score is 10. This is, I'm using the modified pink aesthetic score by Daniel Busser and coworkers. So just this is again the case in 2003 and 2022, good volume maintenance. And again, the key is the prosthesis, the quality of the prosthesis. We also took CBCTs, and these are some cross sections at 5 years and 17 years with excellent volume maintenance. These are the PAs at baseline, 5-year and 17-year, showing good bone levels. So we published basically an article in 2017, basically on the tissue stability that we see on implants that have been placed on sites augmented with autogenous bone, autogenous blocks. And we saw that, interestingly, that those blocks maintain better the margins, the mucosal margin, that the adjacent teeth. We notice more recessions, if any, on the adjacent teeth. As you know, recessions happen as a result of daily tooth brushing, incorrect tooth brushing. So those augmented sites seem to hold better trauma than the adjacent teeth. And that's because they have more bone. The augmentation has provided that implant with proper volume on the buccal aspect. These are a series of articles that we published in Journal Periodontology in 2009, International Journal of Oral Maxillofacial Implants 2011, and in 2017 in Clinical Implant Dentistry and Related Research. So there's a record of these cases already that we have. And again, this basically comes down to the same question that I asked you at the beginning: why is the Pantheon still standing? I think Theo knows the answer to that. You can give us your feedback later, Theo. All right. This is a case of immediate and cortical seal. I'm going to show you briefly a few cases before we jump into, if we have the time, before we jump into more complex cases of block grafting, of states. This is again a simultaneous approach with a cortical seal, an immediate implant placement, an abscess tooth. I'm not going to go through the details, but total absence of buccal plate, 12mm bone dehiscence. Now you could ask me the same question: what do I put in there? Biomaterial or autogenous bone? Well, to me, that is out of the question. I know that I'm sure, I hope that you know by now what I use. And this was again a cortical seal that I used from the tuberosity. This is a 14 weeks when we uncover the implant. The pictures just to show you the full regeneration of the buccal bone. So basically, I connected. The implant is inside. You basically open the little crystal area there to connect the implant and put your healing abutment. So good result altogether. And now the second phase is the restorative phase. Use your provisional restoration. The provisional restoration should be highly polished, as similar as possible to the provisional. You leave them until you can create the papilla for, depends on how long, how quickly that patient heals, 1, 2 months, 3 months, sometimes more. But definitely use that to guide especially intraproximally, guide the tissues and create and match the margin, the mucosal margin with the contralateral side, so that it looks as symmetrical as possible. Remember, some degree of asymmetry is okay. This is the day of delivery. Perfect implant placement, good healthy peri-implant mucosa. And this is basically a sequence of from the pre-op with the tooth in, when the tooth was in, number one, after extraction, after at the time of uncovery and time of delivery, 12 months. You can see the beautiful, this is what we see from the delivery time to the 12 months. The papilla is going to improve and fill in the spaces. So the tissues are healthy, 12 months and 36 months. And I'm starting to gather sometimes I get lucky, and if the patient needs another implant, I ask for another CT scan, and I can see in the CT scan what is happening with that buccal bone that was augmented with the cortical seal. And this is what happens. This is a 36-month CBCT. We see that the buccal bone is thick, is about 2 millimeters thick. And remember, there was a full dehiscence on that site. So, I mean, it's beautiful to see that the bone has regenerated 100%. And the good news is that that is a stable tissue, that is bone that, will be biologically compatible and will not create any issues long term. A different case, we see, we have, all right. If you don't want to, this is another immediate case. You don't have to raise a full flap. And by the way, these days I do more and more flapless. The reason why I'm showing you these nice pictures is because I have raised the flap. And the reason why I raised the flap is, well, I want to confirm that I have done it right. And also you get the chance to see confirm the formation of a buccal plate. It is also easier to treat when you have a flap, but you don't need to raise a flap. You can do this type of approaches. If you have a dehiscence, you can reconstruct flapless as well, okay? Another immediate placement, and these are the x-rays, good bone levels. This is basically another cortical seal, another premolar, the left second premolar, which was presented a fracture on mesial aspect. The tooth was extracted. Again, this is flapless, so I harvested again another cortical seal. The seal is on the left, the particles are on the right. So I used both the seal, and you can see that I placed that seal through the socket to reconstruct the buccal plate that was completely lost. And I also add some particles in there. This is at the time of placement and this is the final restoration with the final crown. This is only, the papillas are still there. Notice that we had a little something there, and when you are doing this type of implants and there are teeth adjacent with multiple crowns, check the vitality, because we had an issue with the molar. The molar happened to be necrotic, and it almost complicates the healing of the implant. It was sent immediately to we didn't know it was necrotic. It didn't look like necrotic, and it looked like fine to everyone. But I mean, when there's a crown, a full crown, that is a risk that I see sometimes could be. So luckily, the endodontist was able to do the root canal and didn't jeopardize the healing of that tooth. So this is the before and the after. The crown the adjacent lateral, premolar has to be changed. There are some marginal caries in there. They did change the other one, but these are the radiographs. One of the difficulties in this particular case, one of the difficult aspects was because I don't like to place long implants. You can if you want. One of the difficulties, like I said, is when you have a lot of bone loss. This case may not look like, but there was a lot of bone loss after the tooth was extracted. All this wall was completely gone. The buccal wall was completely gone. It was difficult to stabilize the implant, and longer implants can provide you with that, and you can also do that. One of the we talked earlier about the pink aesthetics and the provisionals. I find it, it can be risky to place immediately in this type of cases, especially if you don't have good primary stability. It can be difficult to or risky to place an immediate provisional restoration. That is an immediate implant supported restoration. If the implant doesn't have good primary stability, definitely don't do it. Do the Maryland bridge. I think that is safer. Now, if you have a good restorative team and you are able to achieve good primary stability, by all means, you can do an immediate restoration. The Furhauser study was basically showing that there were, all the immediate implants had an immediate restoration, and that helps hold the tissues, which allows you to avoid having to use any type of bone grafting, but the implant has to be stable. Well, I'm not going to bore you with this. This is a research project that we're conducting as we speak. Basically, the whole thing that we've seen is that when we use provisional restorations, the pink aesthetics improve significantly. I'm not going to bore you with this. This is research data, but we don't have the time, so we're going to jump into the harvest. So yes, we harvest from the tuberosity area. You can raise a tiny flap and harvest that type of cortical seals. It is easy with the chisels. You're going to place that one. This was another immediate implant, flapless. You can place that cortical seal on the buccal aspect and fill it with some particles. Remember, you look at the CAT scan. There is a complete lack of buccal bone there after the premolar was extracted. So that 9 millimeter long, that 9 millimeter long cortical seal is going to provide is going to be the new wall of the buccal aspect of that implant. Again, it is like the piece of the puzzle you're going to make. You can trim the seal at your convenience, depending on, you're going to try it on and see if it fits properly. And you can fill the gaps with little tiny particles if you want of bone that you have usually harvest at the same time. Think outside the box. You can, not only you can do the tuberosity, but these days, when you look at the CT scan, I look at everything, all the different sites that I could possibly harvest from. So that is part of your treatment planning, of course. So in this case, for example, I use palatal bone. You'll be surprised, but many times you can find, like this one, you see, this is the palatal. Look at those nice pieces of palatal tuberosity, palatal exostosis that you can see that are near by the tuberosity. You can harvest more if you want from the tuberosity, but this is on the palatal, and those two pieces are basically sitting there asking to be taken and to be used. And of course, there are other sources, not just the ramus and the symphysis. These are greater sources. You have to be a bit more advanced if you want to harvest from the lingual tori, these large exostosis, but they are, great, excellent sources of autogenous bone. Again, like I said, these are a bit more tricky to harvest, especially if they are large. So you need to be careful. But they can provide you with an amazing amount of volume of bone. And of course, they are packed with growth factors and bone morphogenetic proteins. Look how dense that is. Another case of lingual tori that were removed. Anyway, you also not only have the lingual tori, but you also have buccal exostosis. This is the mandible of the patient. I use this exostosis to basically augment a site on the maxilla and molar site. But look how beautiful and large they are, basically there for you to take, and they are not supposed to be there anyway, so use them. That is my advice. This patient have them both left and right. You also have them on the maxillary buccal shelves, that we call them. That is, again, you have an amazing amount of bone in there that you can use. That is a lot of bone, a lot. And that's, you're actually doing a favor, this patient, in terms of cleansability. You're doing a favor if you remove those exostosis, because you're going to make those teeth more cleansable. The patient will be able to brush better, and oral hygiene will be much better. Look at this, another large exostosis. The way you harvest them, you can go either with a tiny, small, round, high speed to outline, or use the piezo device. I prefer the piezo device to outline, like the blue line, your site that you are going to harvest. And then you can also, in this case, I harvested 2 pieces. I went with my piezo and I created a tiny outline on that side to be able to harvest all that with a chisel. By the way, after you outline with your piezo device or your high speed, very fine outline, not too much. You just go with your chisel and chisel it out, and it comes in one piece. Okay. This again, the patient. Look how much bone. This particular patient had way too much bone. But I mean, I'm sure you've seen many of these cases, and you're wondering, what should I do with this bone? Well, you can use that bone to augment any site. Look how much bone. This is anyway. And these are the piezo tips that I use to outline. You can use. There's another tip that I use for extractions. Is like a periodont tip. It's very fine. That it will help you extract, especially those canines that I showed you at the beginning earlier, to avoid any traumatic extraction. Use this. This is for harvesting, but you can use also the tip for extractions. Okay, and that's the case I showed you earlier. Look again. That was the CT scan. Complete lack of bone. Look how much bone we have. The implant is submerged there, so we have to create a little access hole to be able to place the healing abutment. That was at the time of second stage. We have again a nice buccal bone, fully regenerated. And those are the implants. These happen to be 3 implants placed on screw retain position, 5 and 3 years. The idea of not fixating these seals comes from actually, well, I've been researching quite a bit for about 20 years, and I read a lot of literature, and studies like this one from UPenn University show that basically 2 things that grafts from the intra-oral origin, those are intramembranous origin, are better, have less resorption than those from extra-oral origin, endochondral. And also, the very interesting data that these studies are showing is that we don't really need a very rigid fixation on certain areas. And this is what this study is showing. The areas of the snout of the animal, meaning the area of of the face or the front has very little motion. As long as there is low motion, rigid fixation supposedly is not needed. But of course, you have to give some degree of fixation, and we use it by friction. Again, we place that seal. We place that seal, as you can see here, by friction using the edges of the defect, and then we just interlock it and close over it. So again, the question goes for rigid versus non-rigid fixation, right? I think you already know the answer. This is one of the most highly quoted articles in bone augmentation by Professor Matteo Chiapasco and co-workers. That, I mean, if you want to read, I mean, it has a lot of quotes. But we're going to start a little bit with to talk about block grafting. These sites sometimes require, I mean, I definitely advise on severe sites that have no bone to do a state approach. It's definitely safer, and it will provide you with greater volume. Okay. We've published a series of articles on quantitation. Basically, we want to know, and I talked about this earlier. I'm not going to go into the detail, but we wanted to know how much bone we can harvest from the ramus, from the symphysis, etc. I'm not going to bore you with this. We're going to walk into briefly. I'm going to show you this case of block grafting. The patient was treatment planned for multiple implants. He needed an implant also on the lateral incisor, the left lateral incisor. And so I wanted to basically, I needed to augment the site. I decided to take a block from the ramus area and place my implant in a staged approach. Remember, if you are harvesting from a mandible that is, well, not fully, but half edentulous, especially on this side, we're losing reference. It's more difficult to evaluate, and so you better study well your CAT scan and have an idea of the dimensions before you hit the nerve. You want to have exactly a precise idea of how much bone you have, the height and the width, to avoid any complications and nerve exposure. Briefly, I'm going to show you a couple of videos how we did this case, so that you have an idea of how a block transplant looks like. This is at the time of augmentation. The tooth had been lost due to some fracture, periapical lesion as well. Deficient, very deficient ridge. I do my incisions. I always like to do them slightly more palatal, but you can either raise a distant vertical. In this case, I did a distant vertical, distal of the canine, or not. You can extend. Depends on the case. Make sure that the site is fully degranulated. You want to place bone against bone. So I even use sometimes my 15 blades to remove any remnants of soft tissue. This is the harvesting of the ramus on the patient, on the radiograph that you just saw, and I use that. That's the piezo device that I use. I always remember to point toward the buccal. Don't come too much too lingual, because that could, in this particular case, we have very little room of mistake. And that is the other insert that we use, angulated, to do the apical cuts. That way you can harvest. You don't need a big piece. In this case, it's just enough for what we need. Okay, you harvest whatever you need. You don't need to harvest a huge area. So after I harvest the piece, you go with the scraper, and you can harvest some particles as well. The piezo gives you a very homogeneous block, so you're going to have to fixate that. What I was doing right now was harvesting with a scraper. You can do some intramural penetrations with a high speed basically to favor the vascularity of the site, the neoangiogenesis. Not that is not the block. The block is coming. Anyway, I will just play with that, but the block is coming now. Okay. So one of the tricky parts is to stabilize the block at the right position. You try different ways, see how you like it, how it fits, and then you fixate it with one screw is usually sufficient. There's a number of screws that you can use, a number of companies that sell. I'm not going to go into that. I'm not here again. Remember, I don't have any corporate affiliation, so whatever you use is fine with me. I use some particles to basically augment, fill the little voids that you may have in one place and another. Make sure that, to be honest with you, these blocks are so resilient that you probably wouldn't have to do any additional particle filling, but you can. And basically, I also like to. This is at 4 months. You can go as early as 3 months. When we basically expose the site, the block has taken beautifully. We're removing the screw and placing the implant. This is why, hence, the reason why we call it staged. Again, staged because we augment first and we place the implant later. That quality, the quality of that bone is excellent. Type 2. You're gonna have to go all the sequence of drilling, even your foot up, and you will be able to place after augmentation a standard diameter implant at 4.1. That would avoid the use of, if you don't like mini implants and things like that. In this case, I placed a 4.1 millimeter implant. So that's the screw tab. You want to so this is the kickback. It's called the kickback because the implant is very stable. So I'm gonna further send it in with the wrench. Of course, those adjacent teeth need those crowns removed, and the crown removed and replaced and blah blah. But this is the defect before and after. We have restored fully that buccal bone plate. That was the pre-op and post-op. All right. So this is a block from the synthesis. As you can see, that blocks work well, but many people don't like them because of the supposedly morbidity. We can talk about morbidity in a little bit if we have the time. I don't know if we have the time. Let's move on. I want to move on because show you a few cases because I realize that we don't have a whole lot of time. Okay. So we're talking about morbidity. We can ask our colleagues. I have a few cardiac surgeons, cardiologists that I talk to I talk to pretty often, and basically I ask them, do you guys use the most commonly performed cardiac surgery in the world is as you know, the coronary artery bypass grafting. It's very common, over 200,000 procedures done worldwide. Just think about it. So when I ask my friend the cardiologist, do you guys use any type of allograft? Why don't you use an allograft? Because we in dentistry, there's a lot of people using allograft material? And the answer was very simple and clear. No, because that is going to fail. The gold standard is autogenous tissue. So articles like this one in the New Journal, the New England Journal of Medicine, shows you that the type of discussions that our colleagues in our cardiologists, friends in their world, the type of discussions that they are having is not whether or not we should use autogenous tissue. They have it clear already. The question that they are discussing is how they should harvest that autogenous tissue. That is a more healthy discussion. But anyway, so can we avoid bone grafting? This is a case that I did a long time ago in year 2000. It was a severe case. The case had to be, well, basically I used the concept of a split grain fracture to place a few more implants because the patient had a full mouth hip graft by an oromaxillofacial surgeon, and she just didn't want to have more grafting. One of the implants failed and this and that. So an alternative is to do the split grain fracture, which has, well, I mean, it was described by Gaetano Calesini and Scipione back in the early 2009 and 8 and 9. And they described the concept of morphogenetic bone splitting and this and that, and it works well. It works well, however, I mean, the research has shown that we can achieve 3 to 4 millimeters of horizontal bone gain, which is pretty good just by splitting that. But one of the difficulties comes from the prosthetic, the restorative aspect. When you do the splitting, placing the implant on the ideal prosthetic position is more difficult. Is difficult. So you can have this, for example. This is the implant that is a bit more angulated, but then the prosthodontist was able to work around it, of course. But anyway, otherwise, the prosthesis that they delivered was very nice, and the patient was very happy. This is a case of block augmentation. We don't have actually much time. Let me see. Yeah. Okay, I'm going to show you quickly this case. So we had an atrophic pre-maxilla that we had to reconstruct using, I used Ramos. I harvest the piece, split it in two, and again, only one screw is necessary. You can get very good retention with it. You can see the pre-op CBCT and the after. The implants were stable at the time of placement, and that can help us manage this edentulous site. Now it goes, the second phase is the provisional aspect on the final restoration. The prosthodontist delivered a few provisionals, but the patient wasn't happy, and that is something that I'm not going to get into. But one of the things that I always tell my prosthodontists is to open up the spaces so that basically we can have a the soft tissue creating or giving us the illusion of the papilla. In this case, we had one of the difficulties was the intrusion, or basically the extrusion of the mandibular incisors. So we consider intruding the mandibular incisors or doing some sort of orthodontic movement. The patient didn't want to. So the prosthodontist asked me to place the implants more palatal, which is what I did, more palatal than what we usually do. But that it worked well. We also did a connective tissue graft for the canine and a little crown lengthening on the adjacent canine. They didn't want to place any restoration. This is a set of provisionals that the patient didn't like. I personally find these provisionals quite appealing, but the thing that I always ask the prosthodontist again is to open up those interproximal spaces. Okay, so this is the model with showing the access holes for the prosthesis. Again, the patient had a number of provisionals, but finally, I think the final restoration was more, or at least less aesthetic than the provisionals. But the patient was happy, and that is basically what we deliver. On a different approach, again, also block augmentation. We had a defect, obvious defect, that I also treated with the Ramus. I placed several blocks to augment and a single implant. Notice that the approach here is, if you can avoid 2 adjacent implants, do it, if you can avoid it. For that, you will have to work with a good prosthodontist to do a cantilever. And so this is what we did in this case, and it worked well. That's the final restoration. It worked well, but remember that the restoration has to be, hygienic, screw retain, with contacts, proper contacts, etc. All right. This is basically showing you briefly another case I did a long time ago of block grafting. The case presented severe defects on the lateral incisors that had to be, they were going all the way to the apex of the adjacent central incisors. Again, this is a long time ago, so I used to use high speed, not anymore. I use the piezo like you saw earlier. And the key is to degranulate the sites and reconstruct the areas with, you can either, with a combination of particles and a block. You're going to see that with time, after basically after the healing of 3-4 months, in this case was 6 months, we're able to place the implants. The site is augmented nicely, and this is the case at 14+ years. So we go from a situation like this to a situation with fully regenerated buccal bone. This is what I call the blocks that lead to Rome, right? That's why I believe in blocks. The blocks of Via Appia, for example, beautiful place to be. There's a reason why those blocks are still there. They had provided us with the right. All right. This is the CBCT at 12 years. Notice the beautiful bone that is still there, buccal bone. This is at 14 years. Notice this is a different CT scan. Notice how beautiful volume, how beautifully the volume of bone is maintained. And this is how it was when the implants were placed. The patient developed a small recession, but not on the implant, but on the adjacent tooth. And this is what we have shown on that 2017 publication. What we show is that the adjacent teeth were up to 7 times more likely to present a buccal recession than the adjacent augmented implant. Notice that the implants have maintained the implants that had the block on those buccal sides beautifully. The tissue is stable and beautifully maintained. So what I did is a connective tissue graft on that central incisor. There was a little bit of cement actually there. Oops. Restorative lessons learned.